All right, welcome everyone. Good afternoon. My name is Anisa Tatini. I'm one of the PGY3 PM&R residents. I'm joined by Ryan Masterson, who is one of the PGY2 PM&R residents, and Dr. Hoyer advised us on this presentation. This is a morbidity and mortality that concerns timeouts and closed loop communication. So in terms of financial disclosures, Ryan and I have no financial disclosures. Dr. Hoyer has a consultancy relationship with State Farm related to the evaluation of quality in clinical practices, and it's not relevant to the topic of this presentation. So in terms of our objectives, we're going to discuss the outpatient procedure adverse event that occurred. We're going to investigate why the event occurred. And then we're going to review the universal protocol for outpatient procedures, and this is regarding timeouts. We're also going to discuss the importance of closed loop communication in the healthcare setting. And lastly, we're going to outline a plan to reduce the risk of the adverse event happening again. And we're going to talk about how we're going to monitor that our intervention is working. All right, so let's start with the patient case. So patient is a 67-year-old female with a prior medical history of obstructive lung disease, hyperlipidemia, substance abuse, and CRPS after a car accident, who is being treated by Dr. Mayer for chronic pain and bilateral equinovarus foot deformity with Botox every 3 months. The pain medication she's on is 60 milligrams of MS Taunton BID, 100 milligrams of gabapentin TID, and 10 milligrams of oxycodone every 4 hours as needed. So I realize that not everyone in our group is a physician or someone very familiar with Botox and equinovarus foot deformity. So we're gonna break that down. So equinovarus, it can be broken down from its Latin roots. So equino comes from equine, meaning horse-like. And if you ever look at the hooves of a horse, they're the hoof is in plantar flexion, meaning that the heel is up, as you can see from the picture that I have down here. And then varus refers to inverted and adducted. So I included a picture of equinovarus foot deformity. As you can see, this patient up here on the top right has that. Generally, it's something you see for patients who've had brain injuries. You can also see it a lot with children with CP. And the more common phrase for it is actually clubfoot. And then in the case of our patient, she has a dystonia. So dystonia basically means involuntary contraction of muscles, which can result in repetitive movements. As you can see, if your foot is in this positioning, it's very hard to walk. It can get in the way of your ADLs. So that's one of the reasons that we try to treat this. Botox is a way to treat it if it's due to increased tone in the tibialis posterior muscle, as it is for our patient. There are some surgical interventions if it's due to a mechanical reason. And then to go into what Botox does. So to talk about the mechanism of action of botulinum toxin, all 7 serotypes affect the neuromuscular junction, where they produce denervation by blocking the presynaptic release, but not the production of, acetylcholine, primarily at the terminal portion of the motor nerve. Botox usually lasts about 2 to 4 months for our patients. Sorry. And the contraindications are, I'm not sure what happened here. Sorry about that. The contraindications to Botox are generally if someone has a known sensitivity to Botox, and if they currently have an infection. So generally, we don't want to give Botox when someone is being treated for an infection, because there is a thought that the patient can create antibodies to the Botox and it's not going to work as well. And then the black box warning that we tell every patient when we give Botox is that there is risk of distant spread of the toxin. And the biggest risk would be if the toxin were to spread to the muscles for respiration, because that would obviously lead to respiratory depression and many other problems. But this is extremely rare. All right, and because I personally am a visual person, I included a picture from the Bradham Physical Medicine Rehabilitation textbook. So going back to your Biology 101, if you're looking at the neuromuscular junction, you see that in the axon terminal, there are synaptic vesicles that are filled with acetylcholine. You have your SNAP and your snare proteins. Your snare proteins attached to your SNAP, you have the vesicle attaching to the presynaptic axon terminal membrane. It'll release acetylcholine. When you have Botox involved, the Botox will cleave the snare protein, so therefore your synaptic vesicle is not going to attach to the membrane and therefore cannot release the acetylcholine, and therefore the muscle will not contract. All right, so going back to our patient, she presented for repeat 50-unit Botox injections to each tibialis posterior muscle. So prior to the procedure, Dr. Mayer and I obtained consent from the patient. She was not new to this procedure. She's been getting it done since 2017. And we independently reviewed dosing of the Botox. Dr. Mayer and I didn't really talk too much about the Botox injections prior to them happening. However, during the procedure, I misheard Dr. Mayer telling me to give only half of the syringe of Botox, and I gave 100 units instead of 50 units to the left tibialis posterior. So we immediately told the patient that this happened, and we were able to obtain more Botox to give to the other leg. So to break it down even more simply, who was involved in this? I was involved in this, and then Dr. Mayer was my attending. So what actions occurred? I administered the wrong dose of Botox after mishearing my attending. And what was the care team members thinking or feeling? So I will say in this situation, we were not rushed to do this procedure. I will say I am someone who is deaf in my right ear, and it has been hard for me to hear in the setting of masks and face shield currently. It was also a bit loud in the room at the time. So what was the patient thinking or feeling? The patient was calm throughout the entire procedure. She'd had this procedure done many times before, and she didn't have any concerns. All right, and what was happening at the same time? There were other people waiting to be seen in clinic, but we weren't rushed in this situation. And I will say that something good that happened in this situation was we told the patient immediately about the error. It's important to tell the patient what happened and not just beat around the bush with this. And the patient herself was not upset about what happened. She had mentioned that she felt like Botox recently was not lasting as long for her. So she was kind of interested to see if a higher dose would last longer for her. And then what happened that had a bad outcome? Obviously, the bad outcome here was that a patient was given too much Botox, which they might not need. So in the case of Botox, the way we put it to patients is that it can make the muscles weaker. So obviously this could lead to falls. This could lead to impaired mobility. It can lead to difficulty with their ADLs. So we did tell the patient before she left that please reach out to us if she's having worsening ability to ambulate. We could fit her for an ankle foot orthosis AFO. All right, and in terms of patient outcome, I'm sure you guys are all wondering about this. I was too. I recently looked in her chart. She was actually admitted in the last week to an outside hospital for a rheumatologic workup for her lung disease. She was there for about 3 or 4 days. She was not seen by PT or OT during her time there. I reviewed as many notes as I could, and I came across a case manager note that said the patient was ambulatory prior to admission and that she was able to drive herself to the ED. She is due for her follow-up in about a month, so I'll have more information from there. So from this point, I'm going to turn it over to Ryan to talk more.
All right, so a little bit more about why this happened. Task factors involved. There's actually a universal protocol for procedures, which was mentioned earlier, and that was not followed in this case. And I'll get into that a little bit more specifically in a moment. Team factors involved. The resident and attending did not properly communicate clearly during this procedure. There was a miscommunication about the number of units given, and also there was not a review of the dilution of the Botox. Typically, residents like to do a 1-to-1 ratio, and in this case, it was a 2-to-1 ratio, so just a change in the concentration that you're giving. So knowledge factors, as I mentioned, the resident was unfamiliar with this particular dilution of the Botox that was in the vial, and there were no patient, caregiver, or technology factors that were identified. So how can we reduce this risk in the future? Well, the first thing we're doing now is to educating the residents, the attendings regarding this universal protocol for procedures through the M&M presentation today, and then also emphasizing the importance of closed loop communication. So this universal protocol is in place to describe a specific process that's to be used by every participating organization prior to any surgery or invasive procedure. And this doesn't matter where this takes place. It could be in the OR, it could be at the bedside, it could be in a procedural suite. And that's just to ensure that we are working on the correct patient, and typically we identify them by name and date of birth, that this is the correct planned procedure, and that it's done on the correct anatomical side and site. So this policy applies to pretty much every organization within the Johns Hopkins system. So for a timeout, which should be done prior to every surgical or procedure, and like I said, the location doesn't matter if it was in the clinic or at the bedside, it should be performed immediately to the start of the procedure, and it must include the person performing the procedure and at least one other individual. And typically with residents and attending, the two of those are fine. If you're by yourself with a nurse or a technician, and the timeout shall be completed, like I said, before each one. And then I already mentioned that it's the correct patient, the planned procedure, and the site and the side. So one way that we can really ensure this takes place is a closed loop communication. And since the room was loud, there was a lot going on, it could have been a time just to verbalize that what you heard was correct, even if you assumed that it was. So the closed loop communication model actually originated from the military and radio transmissions. It was based on verbal feedback to ensure that the proper team understood a message. And it has 3 steps. The first one is the transmitter communicated a message to the intended receiver. Secondly, the receiver accepts the message with acknowledgement of receipt via verbal confirmation and seeks clarification if required. And the original transmitter then verifies that the message has been received and correctly interpreted, and thus we have the closed loop. So how often do these type of communication related errors occur? Well, my search, there's a number of different values that I found, but according to the Joint Commission of Accreditation of Healthcare Organizations, which is commonly cited, this is approximately 70% of medical errors are caused by problems with communication. Miscommunication is to blame for up to 30% of malpractice lawsuits. And closed loop communication has been shown to reduce the risk of some preventable errors in medicine by making sure that we're all on the same page and that we can kind of mitigate any risks or errors through communication. So there was actually a recent publication in 2019, and it was titled "Debunking the Myth That the Majority of Errors Are Attributed to Communication." And this reviewed 42 articles of different attributions to errors, and it found, it kind of broke it down between 3 types of main errors. The most common being errors of commission at 47.6%, and this was when the wrong action was taken. For example, it could be prescribing the wrong medication. Errors of omission are 14.2%, and this was due to failure to take a correct action. And then errors through communication. And then the last one being kind of a combination of everything that they found a significant contribution between the 3 above, and that was at 28.5%. And this study actually reached out to the Joint Commission for clarification on the 70%, just because it is very commonly cited in different literature. And it was, the author did get back to them, and it was a little bit vague. They just said that communication errors were a contribution. So we're not really sure if it was a little bit of everything or what that was. It wasn't broken down more clearly. So communication errors, we know that they occur for a variety of reasons. Ensuring a proper timeout can help mitigate one of those risk factors. And the closed loop communication can catch these errors before they occur. So moving forward, how can we reduce this risk? Well, we found out that the PM&R department performs approximately 3,000 injections annually. And of those injections, Botox was 1,170 injections. So we know Botox injections are something that we commonly perform. And we reached out to our fellow co-residents just to get a better sense of if it was frequent or infrequent that timeouts were performed, and we found that they were not consistently performed prior to the Botox injections. Typically, the procedure was discussed, as in this case, with the patient during the consent. And we plan to do a monthly survey regarding the use of timeouts and procedures in all the clinics. And if we happen to identify certain sites that are not adhering as closely to the timeout policy, then we would contact that site and make sure that we're reviewing it with the attending and the residents involved. So in conclusion, our goal is to ensure compliance with the universal policy for procedures and to help prevent errors. We want to encourage closed loop communication. And we really, if an error does occur, because no matter how hard we try, they're going to happen at some point, is that we do inform the patient immediately and take any necessary steps to correct that mistake. There are references, and I'm happy to take any questions.
This is Julie. I just had a couple of questions or points. The policy has some procedure workflow related to documentation of that timeout, right?
Yes.
Yes.
Okay, and just, since you're using this for education, I guess, to kind of also maybe explain where that happens in the EMR and just the value of maybe doing an audit versus a survey when you're trying to follow up on compliance with these monthly checks.
So I do think sometimes providers have documented they've done a timeout in the EMR just when they've done the consent form. So I thought about that as well, but I'm not sure if people are documenting they're doing a timeout when they don't do them.
If I can, actually, in this case, I think we more or less did a timeout, maybe not as formally as we should have. But what is missing from the universal precautions, and I think this is a really critical point, is there's nothing written in the universal precautions about dose. And for injections, both Botox and the other place this could be a huge issue also is with baclofen pump refills. It's important that we confirm the dose and the concentration because that makes a huge difference. And that's where I think we fell apart, is that, I kind of instructed the medical assistant to drop the Botox, 2-to-1. I don't think Anisa heard that. And we really didn't discuss before going into the room again that how the medicine was mixed and how many cc's told she actually had the needle in place. And then I told her half a cc and then she did the full cc. But I think that's where it's critical, is that we also include in the universal precaution when we're injecting medication to verify the medication and the dosing and concentration.
But
sorry.
Yeah, I was just, but I think to Julie's point, and actually, I'm just looking at sort of who's participating on the call. We've got, some providers here that do injections and procedures. I'd be interested to hear from how are folks documenting that currently? What is their practice?
And Eric, there's a checkbox on the procedure notes that you do for that. So that's what we usually use. I don't know about others, but again, I think defining what exactly is a timeout is important here. So it's not just that, we confirm that we're injecting the tibialis posterior on the left.
I will say I was surprised when I was reviewing the universal protocol that there was actually nothing about dosing, because that was something that I thought would be included.
I want to add that at Bayview, because we are a regulated clinic, the medical assistants or nurses who are with us are actually required to do the timeout with us in the room, and they're the ones who document it. So it's a little bit more like an OR setting. I think that's different than some of the unregulated spaces that we have. So just wanted to throw that
Anisa, was there any contact with the patient prior? You said there's a 3-month follow-up, but was there any sort of phone call a week after, 2 days after to just check in with her?
To my knowledge, no. Dr.
Okay.
Mayer, do you know?
We had instructed her to contact us, but we didn't reach out to her.
Yeah, just, from a safety perspective and, patient relations, maybe a little bit of a missed opportunity. I know none of us were there to kind of hear how the interaction went, but it's kind of nice from a service recovery to make sure that she heard right and we're not just putting it all on the patient to contact us. And I also have another question. Sorry, I'm a little riled up, obviously. I don't understand the medication enough, but when you said there were no factors, other than it seems like, human at this point, I was just wondering the whole procedure for this dilution, is that something that could be changed with the pharmacy and how you're getting the meds so that there isn't this dilute? Oh, Ryan's shaking his head no. Okay, I didn't know. It enters another thing to have to try and dilute the medicine versus maybe ordering it in the correct.
So we have to dilute it right before the procedure, and then we instruct either doing it ourselves or one of the MAs like what dilution we'd like. So they inject a certain amount of saline and some numbing in there to get the proper dilution per our request. But there's a whole variety of dilution. There's a whole dilution table. It's kind of your preference, how much you're doing, where you're doing it. So there's unfortunately not necessarily a standard that we can do for that, other than if we just want to make it standard for like always doing a 1-to-1, but it's kind of provider specific. And typically the residents all like to do a 1-to-1 just because it's a little bit easier.
Okay, I just didn't know if there were other providers in the health system that use this, and is it something that pharmacy, when you're looking at a system fix, is that something that there's routine dilutions that are used and maybe those can be like assembled or something that would help eliminate?
Julia, it comes in a powdered form and we dilute it in the clinic. So the pharmacy is not involved in that at all.
Okay.
And in terms of the dilutions, it depends on the procedure. So certain procedures are supposed to be done with 2-to-1 dilution, like for migraine protocol, it's always 2-to-1. Also, we usually use 2-to-1 for larger muscles as well. But so there's a rationale for when we use 2-to-1 versus 1-to-1 or some other dilution. But everybody needs to know what dilution we're using. And like I said, the same thing applies to baclofen pumps. In fact, the outcome's much worse if you do it in a baclofen pump. You can kill somebody with a baclofen pump by giving them the wrong concentration. So I think we need to be much more careful about that.
To your point, Eric and Sam and Eric also mentioned, because when you do epidurals or the other forms of injections, there may be also the similar concern that you are bringing up, Sam, on understanding concentrations or dilutions and doses. And how are so it would be nice to know if these forms can be standardized to include those elements, or if this is something beyond our scope. And maybe if they have any of the pain providers in the Zoom, or I don't know who's in the list here, but it would be good to know from those folks doing pain if they have anything that is in the timeout that is include dose and concentration.
I just, Pablo, to your point, I think just the couple of people that I see, I think maybe Alexis and Danny Sova maybe sort of maybe a little bit more interventional than others. I don't know if you guys want to weigh in here.
Hello, this is Alex. Sorry, I logged on a bit late. So I mainly do Botox. So two things. One is there is a drop box in Epic where you have to record a timeout. It asks for a date and time when you did the timeout. So it's always there for you to document. I don't think it stops you from signing your note if you fail to click those boxes, but I always, try to click those boxes every time you do a procedure. And the second thing is like, so for Botox, the dilution is done in the clinic, and ideally just right before you do the injection. So it's not something that you can ask the pharmacy to dilute ahead of time. And once you dilute it, correct me, Sam, there's a shelf life where you have to use it. I think you can store it for a little while in the refrigerator, but it has to be consumed once you've diluted it. So you can't really like dilute it ahead of time. So those are the main things about and then the timeout, really, it's usually you mainly ask laterality of extremity or which extremity you're injecting. I don't think you ask the patient specific muscles, but try to ask, okay, we're injecting the left arm today, it's the left arm. But I don't think you can go and ask the patient specific muscles that that you want to inject.
And that may be an opportunity for us to provide input with revisions of that policy. It might just be that in the past, they're looking at it from your scope of practice. And so that's something we can definitely reach out to have additional clarification for that, for dosing, if there's not a different hospital policy that also talks about kind of read back or labeling of syringes or something like that. I didn't check into that.
Hi, this is Daniel Sova. I would just add that I do most of my work at Green Spring Station, and I do a lot of steroid injections. And at least at Green Spring Station in the clinic, CMAs are not allowed to fill the syringes with steroid themselves. The physician is expected to do that. So I guess that takes care of one closed loop or potential issue where there's a miscommunication between the provider and nursing staff. So I just have to ensure that I'm filling up the correct amount of steroid and the correct steroid, which there's potential there as well as issues. But that is what happens at Green Spring Station.
Danny, just to add to that, in terms of just your documentation, what is your kind of practice right now?
Same thing, you have that checkbox, and also it's always in my note, always making sure to document timeout was performed.
So I have a question of other providers. What do people do when you don't have a resident with you? So I frequently have clinic alone, and I'm doing injections, and I mark that I'm doing a timeout, but technically I don't have the second person in the room frequently. I may have checked the dose and so forth ahead of time, but they're not in the room. I'm just curious what other people's practices are in that situation and whether we're in compliance then.
So this is Alex again. So Sam, similar to you, I don't have an assistant when I do a Botox most of the time. So the only way I can really do I guess a timeout is I talk to the patient. I don't know if that is officially counting as a timeout. Again, we're injecting the left arm today, and then the patient will say, yes, okay, but there's no second person in the room with me most of the time. Also, in Green Spring Station, the MAs are allowed to mix and dilute the Botox. So if I have the time, I try to sort of just verify what they're doing. Sometimes there was a time when they were training new MAs. So I just had to take extra time to make sure that they were mixing the right solutions that I wanted.
Sorry, just to clarify, I was not referring to the Botox, which I think they do. I was, specifically regards to steroids, they do not mix.
That's correct. In I think in Columbia and in Green Spring Station, the MAs do not mix steroids.
That's an interesting policy because I would think the Botox is a more serious medication in terms of
That's true.
that. So I'm not sure why that would be.
That is a good question. It is interesting.
Maybe we can hear from some other attendings just about kind of their practice. I think that's Sam. I think you bring up a good point. Marlee, Story, I see you guys, and I know you guys do Botox as well.
I know I'm not an attending, but one thing that I find useful, in particular with return patients, is printing out the old Botox note because it shows the laterality, the dose, and the concentration. Now, that doesn't help if you have a first-time person who you're trying to distribute to, but I do think bringing that in with the consent and having it on right next to you is very helpful so that you're confirming auditorily and visually seeing the number.
I'm sorry, piping in again. This is Julie. I have the policy pulled up and it says here, timeout process immediately before starting, and timeout must involve C, for ambulatory outpatient settings and clinics, for nerve block timeout, the person performing the block and a nurse. So that's this timeout must involve, that's one of the statements. And then it says pre-procedure, the person performing the procedure and at least one other individual educated in the timeout process. If no other person trained in the timeout process is available, the second person may be the patient with capacity prior to sedation. So this falls into this nerve block timeout, right? Where it has to be.
It does not. Botox is not a nerve block.
Thank you. Okay, so it looks like Alex, I guess, the second person may be the patient. So you're in compliance for that, but just nerve block needs the nurse.
Julie, when you say pre-procedure, what exactly does that mean?
And I can, I'm not smart enough to put a link, I don't know, in the chat. I can send this. They go on to define terms and things like that as well. But this just said for ambulatory outpatient settings like dermatology, ophthalmology, pain, and it just said pre-procedure. So I guess if you're doing this Botox, that's like before you do the procedure, then, so if it's not a nerve block, then it sounds like it falls into this pre-procedure or pre-incision if you're in an operating room. For procedures performed outside the operating/procedure room, nerve block and prep area, bedside procedures. So that doesn't sound like your setting. So it sounds like you're in this ambulatory outpatient setting clinic, and that's all. They just have two categories for nerve block timeout and then pre-procedure, probably because they weren't defining every single type of procedure that you might need a timeout for. So
the one question I did have when we were talking about using the patient as someone to be part of our timeout, what makes someone knowledgeable about the timeout was what I was wondering. Do they need like the formal timeout training, or is it just the physician talking to the patient about what a timeout is good enough to be considered educated in the subject?
right, I'm trying to scroll and read as fast as you're talking, Anisa. They didn't include that in a definition. It doesn't say like timeout or second observer there. The policy's 10 pages, sorry. So I'm trying to see if it's got it somewhere else. I mean, it talks about the responsibilities for the attending physician, procedural provider, surgical team, the verification. I don't know, that might be more than us getting in the meeting right now, but it's definitely worth the team for follow-up with this as you continue to educate. Look and see if it's got more of the definitions in there for you.
Dr. May, you had your hand up for a while. Were you trying to say something?
Oh, I left it up from before. Sorry.
Oh.
So the only limitation we have is in most of my clinics, at least, I don't have an assistant and there's no nurse or MA with me in the room. So it would be just between me and the patient, or if the patient is not knowledgeable, usually they come with a caregiver who can also verify at least the laterality or which extremity. But I usually don't have an assistant, so there's no second nurse or MA in the room.
Yeah, and we can definitely look into this. I guess my thought was, obviously the patient needs to understand what procedure they're undergoing. If it's a steroid injection, what's the purpose? And that, should be done in the consent as well. So I think if there's an understanding what the procedure is, and to your point about the laterality, I think that's, to me, that sounds like I think we should be good with that, but I can definitely, I think we should, just double check on that.
Thank you, Julie, for sharing the policy.
I hope the link works, guys. It's in HPO. There's lots of information in it. Gosh, one of the pages talks about the documentation procedure then. So definitely worth it because they're trying to cover all the different scenarios, or settings where timeouts are done. Great job, guys. Sorry, I asked a lot of questions.
They were all really good questions.
Anisa, do you have any more slides? I don't want to cut you off in case there's anything else to present.
No, this was a pretty a short case.
Very good. Well, we had a great discussion. I think I really applaud you guys for putting yourselves out there and talking about a challenging case for yourselves. Does anyone else have any more comments? Otherwise, we can depart a little early. All right,
Great
wonderful.
presentation. Thank you.
Everyone have a great day, and we'll see you next week.
Yeah, thank you so much, guys, for that. It was great.
Thank you. That's good.
Nice work.
Thank you.
Yeah, great. Well, great discussion.